Well, welcome everybody. We're going to get started pretty much on time here. These are shorter sessions, as you can imagine. These are 30-minute sessions. My name is Mo Bendar. I'm the editor-in-chief of Orthoevidence, and this is now our second um, Insights World Tour discussion. Now, today we are now going to be chatting virtually from Italy. And if I can get to the next slide, to remind everybody, these are a series of small group discussions. So by design, we have kept these to be fairly small because we hope that you will be able to engage with us in this discussion rather than a standard webinar style format. If we go to the next slide here, just reminding everyone this event is recorded. I would appreciate it if you could stay off video and stay muted while our key presenter is presenting. And then once we finish up, we'll open it up for everybody else to come back on video, and we'll hopefully have a discussion. You can use the standard approaches, whether you raise your hand on the Zoom app or you can ask a question through the chat function. And remembering also that this is one of 14 others that we are going to be doing. So just to remind everybody that if you're interested in others, go visit the website and you can see, quite frankly, that there's lots of other opportunities. So if you like this format and you can spare 30 minutes, we do encourage you to take a look and listen to other upcoming sessions. So without further ado, it is my pleasure to introduce a friend and colleague, an orthopedic surgeon, Professor Gustavo Zanoli, who, as you can see here, is the surgical editor for the Cochrane Musculoskeletal Group from Italy. He's also part of GLOBE, which is the Italian evidence-based orthopedic working group. Has been working very tirelessly, I think, for a big part of his career on these issues. And he has a provocative topic to share with us today with some slides. Evidence-based orthopedics, pride or prejudice? Dr. Zanoli.
Thank you, Mo. So let's see if I can get this started. I will try to share the screen. First of all, I start the presentation, then I try to, okay. Okay, let's see. I failed once. Let's see if I can do better the second time. Okay, now it seems to work. Can you see it?
Yes, we can.
Okay, great. And you can also hear me. So thank you, Mo, once again. And thank you, Abby, and everyone who's doing a great work at Orthoevidence to make all these possible. I am delighted and a little bit frightful for this invitation. I'm not so sure I have something so interesting to share with you, but I really hope on a good discussion afterwards. What I presented in the outline or in the insights in the presentation you could see on the website. This is the list. Of course, Pride and Prejudice is the name of a famous novel. I will quote a couple of famous novels throughout my presentations. I hope they are not too much geographically oriented in the culture I live in. These are the points I imagine to talk. I'm not sure that trying to compress as much my presentation as possible. I will go very deep in that, but I really hope that in the end we will try to come out at least with some questions, and maybe you can help me with some answers. So here's my disclosure, which is probably unnecessary here, as I have no conflict of interest for this presentation, but it helps me tell you that besides being a surgical editor for Cochrane, my main activity is being a private general orthopedic surgeon. I perform mostly general orthopedic surgery, and especially, as you can see down in the bottom corner, mostly hip, knees, and shoulder replacement with my colleague Giuseppe Dorito, which you see slide. I think this is relevant to this presentation, as you will see later. So I promise to go quickly through a history of EBM and orthopedics. Evidence-based medicine officially started in 1992. In Italy, we started working on it. You see a photo with very young fellows, which are people who have been working with me for many years. Emilio Romanini on the right, you just next to me, he's probably listening to us and maybe will join in the discussion. And in 1995, so a few years later, we started with GLOBE, with the Evidence-Based Orthopedics Working Group. And in 1998, I think the Italian Orthopedic Society was the first to acknowledge the existence of such a work group, so to recognize us officially as a working group within the society. And so, speaking about pride, it's with some pride that I might say that it was 2 years earlier than our reference journal, the Journal of Bone and Joint Surgery, started its evidence-based orthopedic section, as I acknowledged in a congress later. Then in 2001, one of our prides was that we were able to put all the Cochrane groups which were relevant to musculoskeletal diseases together in Ferrara, where I live, for a meeting of what we called EMASC. We tried to make an international collaboration on everything which had to do with musculoskeletal medicine and evidence. And at that time was my first personal contact with Mohit. I still save this email as a very precious memory for the first contact I had with Mo. Then I was named surgical editor. I was for many years the only orthopedic surgeon in the musculoskeletal group, not the first one, not the only one in the Cochrane, however. And speaking about one of these forefathers, probably the first orthopedic surgeon who really saw the power of Cochrane and of EBM was Alf Nachemson from Sweden. And this brings me to one of the first points I want to make in this presentation. So I was thinking to go back and see what the successes and where we failed with EBM throughout this presentation. So I think he would have probably been proud to know if we had been able to become more appropriate with our spine surgery. This is a very complicated slide which I will not go into detail. When I started preparing it, I was actually pretty sure I would find data to confirm that we now operate less discal herniation than we did in the 80s or in the 90s. I must say the data are not so reassuring, and there's still some kind of practice variations even among countries, as you see here, Nordic countries where you expect surgeons to be very evidence-based and at least with a similar pattern. But still, I can say that this is a similar data we have from Italy when we published our guideline in Italy for surgical disc herniation. I have anyway the impression that in this respect we were able to operate less and operate probably on the appropriate people. On the other hand, when EBM sort of went to take a look at orthopedic interventions, it was not always a success. For example, you probably know these are the guidelines who recommend against surgery for meniscal tears and now also for shoulder arthroscopy in many cases. So this is part of a prejudice, the prejudice that orthopedic surgeons have against ABM and the prejudice that epidemiologists have against orthopedic surgeons. Anyway, as orthopedic surgeons, we are of course very proud of some of our big success. For example, total joint replacement, which of course we cannot attribute to EBM, but also in the field of EBM, in some fields, in shoulder, for example, and also in other very successful international consensus conference, we did a great job, I think. But even when we think of total joint arthroplasty, sometimes it's difficult to see if we follow a stepwise innovation or failed innovation. And you all know the history of ASR and then the metal on metal problems. And here we see some other example of innovations which sometimes failed, sometimes I don't know, Mo knows better than me this history on the right about Kina Spring, so maybe we'll come back to that in the discussion. But I have the impression sometimes, anyway, we didn't follow the stepwise innovation. At least the market didn't do that. Maybe that there was a problem there. So I told you at the beginning, I work in a small private clinic and I do pretty much total joint surgery and implant surgery for a small clinic. But I still feel as a countryside orthopedic surgeon. So I ask myself, from this point of view, what do I really need to avoid this failed innovation? I need a short list of implants which are widely used with other good result and by average surgeons like me. So I don't want to know what only the best surgeons can do. And so, paraphrasing one sentence I heard in one of the AFS. AFS is an intercultural education association for young people, and they talk a lot about intercultural problems. And I heard this sentence saying that politics, rather than promising paradise, should avoid hell. I think this is very relevant to what is happening around the world right now. And I thought the same will apply to us. We should also try to avoid hell, so do it right the first time, as my friend Emilio always says, talking about hip replacement. So thinking of the father or the inspirer of evidence-based medicine and his idea that we should try to make a place where we can find easily all the information, the relevant information coming from the clinical research, which then became the Cochrane Library. I thought that also for registry studies, it would be a good idea to do the same thing. And I tried, in my role as a Cochrane editor and member of the International Registry Association, as part of the Italian arthroplasty registry, I tried to put the two things together. Given that I'm not in any academic role, I don't have any funding for this, this remained for me just an idea. I don't know if it's good or not. Maybe we have time to discuss it. We proposed even a funny name for this group who should work on that within Cochrane. I think someone else is working on that, trying to summarize all the evidence in a single from different registries, so you don't have to read 10 reports of different registries to find out which is the good implant for you. But I still think that doing things together is better, and I really hope that Cochrane can someday will find a way to summarize this evidence. So now we come slowly to the second part or end of this presentation, and the inspiration comes from an editorial we wrote with Emilio, mainly as a first author, on the Italian journal and the epidemiology journal of the Italian Society for Epidemiology, discussing exactly what my point is in all this presentation. So if there is still a problem between epidemiology and orthopedics, if there is still a gap between these two words. And so as the main character in Joseph Conrad's novel, I think EBM and evidence-based orthopedics is entering this age, is entering this time of life where you have to make important decisions. And so we wondered, for example, looking back, of course, we did something good in this year. So when we started the old orthopedic surgeons would tell us, oh no, please don't push too much for guidelines. You do with them, if the ministry calls you, you help them, but not too much. Don't push for too news. And then suddenly there was enthusiasm on the other side, and they asked us to produce all the guidelines for everything in orthopedic surgery within 6 months. So this has now changed. So the culture of what a guideline is and what ABM can do for everyday clinical practice is a little bit better. We were able to produce some guidelines, official ABM guidelines for Italy, but probably less than one a year. And still the majority of the information which you can find on the web and even on official website comes from non-EBM guidelines. So we feel like sometimes when we read them, jumping in the DeLorean and going back to the future. So why this Pride and Prejudice? Well, I think probably there's some pride and some prejudice on both sides. Probably the word of EBM guidelines production is sometimes too proud, and we tend to produce huge guidelines only on few topics which take too long to produce and too long to read. At the same time, even we as orthopedic surgeons sometimes are too proud. We probably think that as it was in the work of this surgeon in the 18th century, which I quote down here, simply that surgery is superior to medicine, so we don't need to do all this. On the other side, so we can ask ourselves, are we playing dumb as orthopedic surgeons, or sometimes even EBM could settle for good instead of best? Going to conclusion, I think we have two extremes here. Ivan Illich saying that probably medicine hasn't helped, modern medicine hasn't helped people at all, and the hopes of David Sacken when he proposed EBM. I'm not sure. These are some data from Italy showing that we are doing better on mortality, but not so much on quality of life in later years. I'm not sure what we can say about EBM. So in conclusion, what really changed our way to think in this moment is that something is happening at the same time together all over the world. So we worked together on the COVID guideline for orthopedic surgeons for Italy, starting from the great work done by Orthoevidence. And we were able to do this in few weeks every time, and altogether the whole process for 3 different versions didn't take us more than 3 months. So this is maybe something we can take home. Sometimes we can avoid some of the rituals of EBM and try to give fast answer, which are good enough, better than nothing, so to say. I will leave some of these points to the discussion. Maybe I can show this slide again later when we discuss, so because I see now I've already spoiled most of our time. Thank you.
That's wonderful. Thank you, Gustavo. If you were able to stop sharing the screen, we'll get to the group panel. And I'd encourage all of you who are able to just come onto the screen and maybe put your videos up, and might be the way good for everybody here. And while we're starting, why don't we address that one question that was already raised by Dr. Desai, I believe. So here's the point, right? He writes the following: commerce drives science. And they talk about, for hip fractures, for example, you know, the more fancier intramedullary nail devices versus maybe the sliding hip screw device. And the discussion saying, well, maybe, you know, we've seen commerce drive things rather than anything else. The broader question is, and I raise that with anyone who has a thought on this point, is who do you trust, or how do we begin to develop trust, especially, and let's use the argument of where we've been in the last 6 months or so. During a crisis or when information is rapidly needed, Gustavo, how do we, as individuals who are looking to get best evidence, where do we go ultimately? Where should we go? Knowing that you've just pointed out that 50% of our guidelines are based on faulty information or are poorly conducted. So where does the user go? And especially when information is critical and you want that information to be valid.
I think there's two sides of this problem. On one side, I think we cannot skip the problem that we, even as orthopedic surgeons, we should introduce among the tools that we use every day some clinical epidemiology. We must know a little bit of research, of clinical research, to be able to identify at least what is certainly totally wrong or market driven, or at least not so scientifically sound as we would like. So we need to do some study in that respect. We cannot think there is always mom and dad telling us what to do. On the other side, of course, there is a great problem of credibility. We have seen this with the fake news in the big world. You know, people didn't know who to believe at the beginning of COVID. For sometimes all the virologists were the Bible, and then they started arguing to each other. So
right.
That's a bigger problem. Of course, I'm here also as a Cochrane editor. I wish Cochrane could be, as it is for other branches of medicine, a starting point where to find good evidence. The problem is that for surgery in general and for orthopedic surgery, there's still a lot of work to do so.
Well, and that's the point, right? So, I mean, you're seeing questions pop up, but you know, when information is rapidly changing, right? You know, and we talked about the ideal. You know, you had a slide there. How do we determine when it's the right time to sort of adopt a new technology, a new treatment? When do we have enough information, I guess, at a broad, and do we have to wait for guidelines? So in the absence of a guideline, a single large trial or a single trial comes up, you know, this becomes the challenge, right? So, you know, we talk about that evidence-based medicine has pushed us forward in so many ways. But the challenge always exists, and the detractors will always say, but you can never base practice on a single small study, or most guidelines are flawed because they're based on flawed data. Innovations are rapidly changing. So by the time you evaluate something else has happened in a rapidly innovating area. These are all the challenges that we face. But let's get back to that fundamental question.
I think
when do we have enough?
Yeah, at the moment, I think the problem is the other way around, because, I mean, your question is perfect in an ideal world where evidence would control, in fact, what we introduce. And then probably we would be here complaining that because of evidence, we introduce technology too slowly because we wait for evidence.
Right.
And then we would have that problem. So we can discuss this problem, which is a theoretical problem. What happens in reality is that we introduce new technology based on something else, based on, as our colleague said, commerce, based on market. I think that it's true for Italy and for most countries I know that you don't need evidence to introduce a new device into the market as much as you do for a new drug. So I think the problem at the moment is right the opposite. So how do we take control of the introduction into the market of innovation without, you know, spoiling the creativity of orthopedic surgeons? I don't know if there's a good solution. Of course, then we would have to update it very quickly. But we've seen that when there is interest, it is possible. We did this for COVID.
Right. So let me ask some others who have had these experiences. In the last 6 months, for any of you on the who are listening in right now, how have you felt about the quality of the information you're getting, and where have you gone to get your trusted source of information? I see Ahmed there. Ahmed.
Yeah, Yeah, I was gonna say, or Mo, and for everybody, I have been working on find some evidence about rehabilitation at the COVID time, and it was really hard to find like, high quality evidence. We barely find any evidence basically at some time. But when we look at when we're trying to find a good quality evidence, I always look at like either Cochrane review or maybe highly cited articles or very well known journals like New Journal of England or JAMA.
Okay, okay. So broadly speaking, what you're saying is, I will always go in times of uncertainty to high quality sources, trusted sources, where I go. So you'll look at the groups that you work with, you trust, high impact journals, or organizations such as Cochrane. And someone politely said Ortho Evidence, so thank you for that. But places like that make sense. Okay, that's reasonable. Is there any other place anyone else has gone during this time to get information? Doesn't look like it. Looks like we're all kind of in the same mindset. Well, what about this situation, Gustavo? And I'll raise it with others. Early on in COVID, it was a novel virus. In other words, we didn't have randomized trials. We didn't have anything. In fact, the majority of the evidence that we were getting was coming from experts. That was the majority. It was commentary and experts. So let me ask this. Is expert information considered evidence?
Well, to me, yes. Mm, I mean, we've been used to this in orthopedic surgeon. We still do a lot of, I mean, most, if we exclude those 5 or 10% of things that we really have studied well, like for example, femoral fracture, there is a guideline, the NHS guideline is 500, 600 pages. Apart from that, of course, we do a lot of everyday clinical decision just based on what someone else taught us.
Right.
I think that the next step would be, as it was, for example, I quoted Parvizi's consensus. The next step would be trying to make this expert opinion a little bit more standardized with consensus conference, for example, and not just because my boss says I have to do it so.
Sure, but I think we're also realizing that an opinion is just that, right? In terms of bias, and I believe this, but I believe this based on a host of other things. The clinical trial at one extreme is trying to limit bias to some degree, right? To randomization, concealment, blinding, all those sorts of things. But there are going to be experts that we will be more trusted than those who are not. So some might argue, and this is to points that are made around the issues of bias. So one would be a transparency in any conflicts that an expert may have, a prior history of research in the area that is well respected and understood by that individual, a sufficiently large network of people who support the views of that individual, for example. Could be other potential things that would help us. Like, for example, during COVID, you can argue what you like, but someone like Bill Gates, who's who has the Bill and Melinda Gates Foundation, was very early on a focus of everyone's attention. The New England Journal specifically went to him for editorials, multiple editorials actually he was giving around that time because of his vast experience and the amount of money that had been raised for research, that he might be someone who at least has some concept. Now, he's not a content expert, but he is someone who has been speaking with everyone to be able to raise that. So that's an example of someone that became very prominent in a time where we did not have large clinical trial data. And it raises a very good point. But, here we are, right, in a time where we're trying to figure out how to make sense of good information. And you can look at it from the point of everything is prejudiced, going back to your title, right? Where does everything, the glass is always half empty. There's all kinds of problems. Our job, I think, as all of us here, should be to say, how do we find the pearl? How do we find what's good? And how do we get to what's good? And I think you've nicely articulated in many ways where we can find some of those pearls as we go forward. We're nowhere near answering this problem. We're nowhere near, this discussion can go on for hours and hours. And so I just want to make sure, because these are short sessions and I want to let people get back to the rest of their day, And thank you for spending some time with us. But is there any other comment that anyone else wanted to make that hasn't been addressed yet as our closing comments before I close out?
Just another quick point, more if you don't mind.
Sure.
So I think like evidence-based medicine also is about using the best evidence we have. So we don't always have to have RCT, but any level of evidence is better than having no evidence, I guess. So you're right. So even the expert opinion is like the lowest level of evidence, but at least we're trying to do the best for the patient.
Absolutely, right. And I think on that note, it's an appropriate way to close this out and encourage you all to continue on this journey, right? To be figuring out what makes sense and what doesn't, signal to noise. And Gustavo, thank you so much. Thank you all to the small group. This is exactly what we're hoping to do, is have these debates. Join us for others if you can have time to pop in, and we'll definitely, continue these discussions in various formats. So thank you all. Thank you, Gustavo. And we'll have this online very soon.